Hi, this is Professor Blades. We're going to talk about Chapter 26, Management of Patients with Dysrhythmias and Conduction Problems. So hopefully you watched the first video just talking about how you can read ECGs. The one thing that I will always tell you is at the beginning of every chapter, there's a glossary of terms, and it is very important that you expand your medical vocabulary. So if you do not understand or know what some of these glossary terms are, I would recommend that you do some cards or something and start building your medical vocabulary a little more. Okay. So the disorders of formation or conduction or both of electrical impulses within the heart. So that's a dysrhythmia. At the end of the other chapter or the other presentation, we talked about an irregular heart rate. It was a sinus irregular heart rate. So there can be some different causes that affect conduction. It can be rate, it can be rhythm, it could be both the rate and the rhythm for the patient. It can alter the blood flow and cause hemodynamic changes. So if you think about the way the heart and the blood flow that we talked about in the last chapter and the last presentation, if there's something wrong in trying to get the blood, that oxygenated blood that comes in and goes out to the body, then there's going to be problems for the patient if they don't have that oxygenated blood flowing all the time, right? It can cause necrosis because the blood flow is not the right way. The one thing that I always tell people is you need to remember, why do people get frostbite? Because the body is protecting the internal organs. So that's why their fingers and their toes and their extremities get the frostbite first, because the body automatically, it'll make all that blood circulation stay within the torso where all the vital organs are, so that it makes sure it gets all the oxygenated blood. And so it's kind of the same thing if you have a dysrhythmia, not to that point, but it can cause problems with other organs if they don't get the right perfusion. And so you get it diagnosed or by analysis of an electrographic waveform. So there's different types of dysrhythmias. You have atrial and ventricle or ventricular. Remember, you have atria in your heart and ventricles in your heart, right? So if I go from here to this other presentation that I have, um, so let's look at a flutter. So if you remember on the other video when we were talking about um, sinus, um, normal sinus rhythm or sinus rhythms, and you go through those 5 steps of figuring out a rhythm, then with the difference areas with this is atrial tachycardia, but the P wave, the atrial P wave, peaked, flattened, notched, or diphasic, may be hidden due to the fast rate. Okay. Everything else is pretty much the same as far as the distance with the PRI when you measure it, or the QRS. Obviously, the rate here is much quicker because you're going to have that multiple R's because this is tachycardia. But if we look at this one or this one, as you can see, and I wish I could make this a little bigger. I think I can. Okay, so when you look here, that looking for a P wave, that one is inverted. You can see a little dipping notch. This one is kind of a little small reversed hump. But the rate here is so fast you can't even see much of them. But if we go to a flutter, then they all look like P waves, right? So what happens with a flutter, the impulse travels in a circular course in the atria. So what's happened here is you don't have an SA node firing, you have the atria firing. So that initial pulse that causes the heart to contract starts somewhere in the atria, not in the SA node. So now that initial firing is happening at one of these, and it's kind of ping ponging around a little bit, right? The impulses travel in circular course in the atria. So that's when you get the flutter. And if you look at how you measure flutter or how you read the flutter, um, so the ventricular can be regular, irregular. The rate is very high, and it's usually a sawtooth appearance. That curved one is a little bit different than what you usually see, which is this sawtooth. That's how you can always recognize an atrial flutter rhythm, because most of the time it's going to have that sawtooth appearance in the middle, not that smooth looking rounded thing. These are some other atrial flutter rhythms. As you can see, there it's actually more sharp, right? This one's kind of jagged all over the place. The only thing you can say about the flutter is the flutter inside, or the marks in between the R to R, do look pretty consistent, right? And then you have atrial fibrillation, which is another dysrhythmia from the atrium. And what happens here is there's an abnormally fast and chaotic heart rate. The atria quiver rather than beat. So, on a normal, so in atrial fibrillation, what happens is instead of squeezing the blood out from the atria into the ventricle, it quivers. The atria never do have that full electrical impulse like they should have. So here's the rules for atrial fibrillation. You can't really measure the regularity or the ventricles. The P wave, there isn't one. You have more atrial fibrillatory F waves. So without a P wave, there's no PRI, but you do still have the QRS. So if we look at this slide, as you can see, the SA node fires, or the SA node's here, and here's the atria. They just don't ever have that one little oomph that goes. The SA node does not fire, sorry, but the SA node never. They it The atrial do not contract the whole way. They just kind of quiver a little bit. So what happens with a patient is that the blood can pull at times in the atria because it's not squeezing it all out with the electrical impulses and with the contractibility. And so that's why people on with AFib usually are on a blood thinner, because that blood can clot in the atria. Most of the time they're on some kind of rhythm medication to try and help that AFib not occur. Okay. And so this is an AFib, as you can see, and you can see it more down here. There is a a QRS, and there's kind of a T, but there's never a P wave. And you can see it. This is the second lead. That's why you can see this quivering a little bit better on the second lead. A lot of times too, when you're on a cardiac floor, in order for them to read the rhythm, they may look at the second lead because it might be easier to be seen. And so then, sorry, my computer's doing weird things. So if you look at this AFib, as you can see, it's, if you're counting the R to R, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, they've have a rate of 110. Where this one down here is, if this is a 6-second strip, it's 1, 2, 3, 4, 5, 6. maybe 60. So we usually say an AFib rate, if it's over 100, is uncontrolled, and under 100 is a controlled AFib. And once again, this is just different versions of AFib here. And then this is your sawtooth. So this is your atrial flutter, right? Okay. We're going to go back to the other um, presentation with chapter 26. Okay. And so here we are with we were talking about the different dysrhythmias. We'll talk about ventricular a little bit later. You have PVCs. If you ever have like feels like a little hiccup in your heart, that you probably have had a PVC. There are medications that can cause that. And sometimes everybody just has PVCs. It really can happen just out of the blue. Some people get them a little bit too regularly, and so they may have to stop a medication, or you can also take something like metoprolol, which will help with that type of issue. And then ventricular tachycardia, ventricular fibrillation, and ventricular asystole. We'll see those some samples of those. So normal electrical conduction, like we talked about before, you have the SA node fires. Sometimes then you have an AV node that gets hit with that electrical current, and you have conduction. You have the bundle of His to the right and left branches through the Purkinje fibers and the depolarization and repolarization. So depolarization is stimulation, and that's your systole. That's your number. These are your blood pressures, right? The depolarization with the polarization. And then we have conduction abnormalities. You have a first degree AV block, second degree AV block, a type 1, also known as a Winky block, and you have a second degree AV block type 2, and also a third degree AV block. So we're going to go back and talk about we're going to talk about the blocks as well. Okay, so this is supraventricular tachycardia, or SVT. So this is one of those rhythms that you're going to have to do something about. Okay, we call a lot of things SVT: sinus tachycardia, atrial tachycardia, atrial flutter, and junctional tachycardia. Um, because the heart is beating so fast, you can't tell if there's a P wave. You can't really measure anything. So that's why all of these together are known as SVT, or supraventricular tachycardia. And you can see here, there's really no distinction. Everything might change, or it's so fast you cannot do those things. And this is just more examples of supraventricular tachycardia, when that heart rate just beats so fast, you can't really distinguish which one of those above it is. So now we'll talk about a heart block. So it's a delayed or a failed conduction of an impulse from the atria to the ventricles. And so, like we were talking about on the other slide, these are the types of heart blocks. You have a first degree heart block, you have a second degree type 1 and type 2, and then you have a third degree heart block, which is a complete heart block. This one is very, very, very bad. You have to do something about it. We're going to talk about the difference between the second degree heart blocks, the type 1 and the type 2s. So, in a heart block, the first degree block, all impulses are conducted through the ventricles. So, it's not really a true heart block, but rather a delay. In the second degree block, some impulses are conducted through to the ventricles. And then the third degree, no impulses are conducted through to the ventricles. So that's why I said a third degree is really, really bad, right? Because nothing's getting through to the ventricles. So if you don't get impulses through to the ventricles, they don't empty, right? They don't function. So a first degree heart block, the regularity, it depends on the underlying rhythm. So what we would normally say with a first degree heart block, if you were assessing it and giving it a name, you might say they have sinus brady with a first degree heart block. Okay. It's not its own rhythm. It it is in addition to the rhythm. So that's why it says the rate depends on the underlying rhythm. So how fast is it beating kind of thing. Your P waves, remember we talked about P waves being upright and uniform. Each P wave will be followed by QRS. So it's kind of a sinus rhythm kind of rate, right? Or it looks like it. Oops. Um, Here's the difference. This is where that measuring comes into play. The PRI is greater than the 0.20 second, and it's constant across the strip. So it can't be every once in a while. It has to be constantly a wider PRI. And then the QRS is the same. It's less than 0.12. So if we look at this is a first degree heart block. So as you can see, the P wave goes, and then it's this extended distance between the P wave and the QRS, right? There's a distinctive difference between the two, and it's very consistent. So 1, 2, 3, 4, 5. So this rhythm is probably sinus brady with a first degree heart block. Okay. And then here's another first degree heart block. So as you can see, here's your P wave. This one's cut off. Here's your P wave. Here's your P wave. Here's your P wave. It takes a long time to get to that QRS, right? It's not that nice little pretty rhythm we saw before. Another one. So this just shows how you measure it. Okay. And then this is another first degree heart block. Once again, those P waves are not close to everybody else. All right, so then we have the second degree heart block. The block at or below the AV node. Okay, so your AV node's right here. So the block's going to be here or it's going to be somewhere down here. Okay. So in a type 1, the block usually occurs in the AV node. Only one P wave at a time fails to conduct, and it's the grouped beating scene groups are usually separated by pauses. So, and then here's the second one, a second degree. This is the other thing as you go through the 5 steps of figuring out what your rhythm is. So the R to R is irregular and in a pattern of grouped beating. The rate is usually slightly slower than normal. So normal 60 to 100, right? P waves upright and uniform. Some P waves are not followed by QRS. PRI that progressively lengthens until one P wave is blocked, and then the QRS is the same. So, and remember when we talked about these, what we call this, let me go back. So it's a winky block. Okay. So there's a little poem thing that goes along with it. You have the P wave and you have longer, longer, longer drop. That means it's a winky block. And so there's a few of those that you can learn. So let's look at this one. So here's your P wave, here's your P wave, here's your P wave. So they're showing you in 0.26 seconds, then it went to 0.28 seconds, then it went to 0.32 seconds, and then the P waves here, but there's no QRS. So that's the problem. Longer, longer, longer drop. Same thing here. Longer, longer, longer drop. There's no QRS. And that makes a winky bach. So this one, same thing. Here's your P. Your P's kind of right there. And your P is kind of back here. It's almost in the T wave. And then you have this P wave on the T wave and nothing. So that is a second degree heart block type 1 or a winky bach. Okay. Just some more pictures of different ones. So then you have a second degree heart block type 2, and this block usually occurs below the AV node. Sudden failure of conduction within progressively increasing PR intervals, and they very rarely, compared to type 1, but this block is more dangerous. So when you're looking at rhythms, dangerous rhythms, We talked about a type 3. Now we're talking about a heart degree block type 2 as being bad as well, right? So when you do the 5 steps to look at that strip, the R to R interval can be regular or irregular. The P to P interval is regular. Okay. So the rate's usually less than 60. The P waves are upright and uniform, more than one P wave for every QRS, and the PRI always constant for the conducted beat can be greater than 0.20. So it can be bigger, right? And then the QRS is less than 0.12. So the QRS is not affected in these. So let's look at this one. Here's your P, your QRS, and your T. Here's your P with no, and there's no QRS. Here's your P, QRS, and T. Here's a P, and then there's no other beat. So it doesn't fire the whole way. So that can be bad, right? You want to have that QRS. So here we go. Now we have 2 of them and no QRS. Then you have 3 regular beats and then it dropped a QRS. So you see the difference between this one and type 1. So you have the P's, but you have more P's than QRS's. But it is still pretty consistent, right? It is still the PRI where there is a PRI, it is constant. There's nothing missing, right? You just might have a few extra P's in there. These are just some more examples. So then what's going on here? You have a QRS and a P and a QRS and a P and a QRS and a P. Oh, and something's missing, right? It didn't fire. And then the same thing here. There's your P, no QRS. There's a P with no QRS, and same thing again. So the second degree heart block, this is the difference, right? Some impulses are conducted through to the ventricles and some are blocked. So you have that type 1, the PRI progressively lengthens until one impulse is blocked. And then the type 2, you have the PRI consistent with when present, and the AV node lets some impulses through and blocks the other. And then we have our third degree heart block. Okay, so the P to P is regular and the R to R is regular. The rates, atrial rate's usually 60 to 100, junctional rate is 40 to 60, and ventricular rate's 20 to 40 if focus is ventricular. The P waves upright and uniform. There are more P waves than QRS complexes. And we'll see the difference between this and the second degree type 2. There's no relationship between the P and QRSs. The QRS is less than 0.12 if focused is junctional and greater than 0.12 if focus is ventricular. So you'll be able to tell if it's a junctional or a ventricular rate. So if you look at this one, this is an example. The P is just wherever, the QRSs are wherever. This one's kind of small. So remember, this is the P to P is regular, R to R is regular. There's no relationship between the two and no consistent PRI. So if you look at this one, as you can see, there's P's all over the place and the QRSs are just kind of there. Sometimes there's one in front of it. Sometimes it's way in front of it, but then sometimes there's just one on its own. And then this is another one and another example. And it just kind of same thing, lots of P's, there's QRSs, sometimes they're together, sometimes they're not. So this little table is really good to have. It kind of breaks it down for you. So if you are trying to figure out what kind of heart block you have. And anytime something says it's an asystole, it means there's no electrical impulses. So this is what you're going to get. If you notice, though, that it's not a straight line like they show on television when someone passes, but it is kind of straight. There's no kind of bumps. So here's your heart block poem for you to, you can take a picture of this. It just helps you to remember trying to figure out if it's heart block or not. Now, I apologize. This is probably a little bit longer of a lecture than I normally give, but these are important to kind of know. So, once again, these are the dysrhythmias that we talked about. So there's your heart blocks. And this is the relationship of ECG complex lead system and the electrical impulse. So we kind of saw this before. These are 1, 2, and 3 leads, but it shows you the difference of where they are when you're reading each lead. And this is ECG electrode placement. So this is where you put a 12 lead. And so the electrical or the ECG, the electrocardiogram, um, electrode placement, electrode adhesion, types of ECGs, ECG interpretation. So you have all these things that the ECG reads. It reads the P wave, the QRS complex, the T wave, the U wave, the PR interval, the ST segment, the QT interval, the T to P interval, and the P to P. And so when you're analyzing the ECG rhythm, you have normal sinus rhythm, and then you have the sinus node dysrhythmias, the sinus Brady and sinus tach, which we've already done on the other slide. But you can tell by this one that the P to Ps, the R to Rs, and then in a 6-second strip, 1, 2, 3, 4, 5, 6, 7. So that's a heart rate of 70. And then this is the ECG graph and commonly measured components. This is similar to the other um, lecture that we did. Same thing, just on one slide. And this is a normal sinus rhythm. And why is it normal? Can you count it? Can you see all the P waves? Remember the 5 steps. And this is sinus Brady. And once again, if you count between the 6-second strips, let's say this is all a 6-second strip, 1, 2, 3, 4, 5, 6. So that's a rate of 60. And then sinus tach, a little faster. You still have your P's, your QRSs, and your T waves. And then you have sinus arrhythmia. So the difference only is you still have your P's, your QRSs, is if you measure from R to R or from P to P, they're slightly off. As you can tell, there's a little bit more space. Didn't skip anything. It's just a little bit wider. All right, so we have question number 1. The nurse is preparing a male patient to have a 12 lead ECG performed when prepping the skin. The nurse notices that the patient has abundant chest hair. What is the most appropriate nursing intervention to improve adhesion of the ECG leads? And it's going to be to clip that hair. We try not to shave people as much because you can nick them, but if you can just trim the hairs, because the ECG leads has to be able to adhere to the skin to get a good reading. And remember what I said in the other video, we treat the patient, not the rhythm. So if you're working on the floor and the tech says, the teletech says to you, please go check the patient's leads, or we're not getting a signal, we can't see the telemetry, you need to go check your patient. We have unfortunately, I know of a situation where they kept calling, telling the floor to go check the patient, get their box back on them. They had been off the floor. And by the time they went, the patient was actually dead because they did not have their ECG on. And they obviously could not call a code because they didn't know what was going on. So let's look at the nursing process for the care of a patient with a dysrhythmia. You need to look at what the causes of the dysrhythmia are, the contributing factors. The dysrhythmia's effect on the heart's ability to pump an adequate blood volume. We talked a little bit about AFib. Some patients can be in AFib and have no problems with being uh, in AFib and staying that way. And other patients, once they go into AFib, they have shortness of breath. They have exertion issues where they don't have the ability to walk down the hallway without being really tired. So, you definitely need to make sure that you are watching your patients to make sure that you're treating them and not the ECG. Also, same thing again. I mean, if your patient's short of breath and You can't, and you need to check their blood pressure. You need to make sure that their leads are on correctly, things like that. So we're also going to assess indicators of cardiac output and oxygenation, which is what I was just talking about. And then the health history, previous occurrences of decreased cardiac output, possible causes of this dysrhythmia. Have you had this happen before? Do you have a history of AFib? And then all the medications they take prescribed and over the counter, because there's some herbs that can actually cause a dysrhythmia, especially if they're combined with prescribed medication. And then you have psychosocial assessment, patient's perception of the dysrhythmia. How's that patient feeling? Are they nervous? Things like that. And then you have the physical assessment. You're going to assess their skin. Is it pale and cold because they're not getting good perfusion? Signs of fluid retention, JVD, lung auscultation, and the rate rhythm of apical and peripheral pulses, their heart sounds, their blood pressure, their pulse pressure. And um, then with diagnosis, decreased cardiac output related to inadequate ventricular filling or altered heart rate, your nursing diagnosis, anxiety related to the fear of the unknown outcome of altered health state, and deficient knowledge about the dysrhythmia and its treatment. And collaborative problems and potential complications. They could go into cardiac arrest. They could have new undiagnosed heart failure. And there could also be a thromboembolic event, especially with AFib. Remember, with AFib, that blood is just kind of quivering and pulling in the. So, the goals of the nursing process for the care of the patient with a dysrhythmia, of course, eradicating or decreasing the occurrence of dysrhythmia to maintain cardiac output, minimizing anxiety, and acquiring knowledge about dysrhythmia and its treatment. So, some of these patients, AFib is new for them. It's very scary. And you need to, they may have anxiety. That may make their heart rate go up. What makes your blood pressure go up? Pain. Anxiety can make your blood pressure and your heart rate go up. Your heart rate can go up with pain. Um, and the shortness of breath that they have may be from exertion. So then we have nursing interventions. So you're going to monitor and manage the dysrhythmia, reduce their anxiety, promote home and community-based care, educate the patient about self-care and continuing care, especially patients who may have heart failure. Then they have to look at their diet. Can they have salt? Not have salt? How do they keep that edema from forming? And then nursing interventions, monitor and managing the dysrhythmia. Of course, you're going to assess the vital signs on an ongoing basis. If a patient has decreased perfusion, they can have lightheadedness, dizziness, they could faint. So you want to make sure that you walk them to the bathroom or someone assists them to the bathroom. If they're hospitalized, get a 12 lead, continue their monitoring, and then monitor the rhythm strips periodically. We do have teletext depending on if you have telemetry on the unit or if it's in a tele room. You can all, and then if you do remote tele, you can usually print off a strip off the little box that the patient has on them, so you can see what they've been doing. Um, and the teletechs are going to be watching, the people who watch the monitors are watching for pauses in the EKG or the ECG and, different things. And then you also have anti-arrhythmia medications, and there's also the 6-minute walk test. I did not mean to turn that off. So let me go back to sharing. Okay. And so the 6-minute walk test is done. The tester will measure the blood pressure and oxygen level, usually with a pulse oximeter before the patient starts to walk. And then the object of the test is to walk as far as possible for 6 minutes, and usually walk at a normal pace. And that's how they do the 6-minute walk test. And so, to minimize anxiety, what are some of the things that you can do as a nurse? Stay with the patient, maintain safety and security, discuss emotional responses to the dysrhythmia. How's your patient feeling? Are they short of breath? Do they feel nervous? If you've ever seen a patient who has difficulty breathing, they have very high anxiety, severe COPDers, or if it's something new. Obviously, with COVID, this is a new thing of having patients not being able to breathe very well. So you help the patient develop a system to identify factors that contribute to the episodes of the dysrhythmia, and you maximize the patient's control. So we're going to educate that patient about treatment options, therapeutic medication levels, how to take pulse before medication administration, how to recognize symptoms of the dysrhythmia, and then to measures to decrease the recurrence, plan of action in case of an emergency. And we teach patients, families CPR. They may actually save their family member's life. And then referral for home care. Hemodynamically unable with signs of decreased of oxygen, significant comorbidities, socioeconomic issues, limited self management skills, and an electronic device recently implanted. So these are just some reasons to refer a patient to home care. And and then also the care of the patient with the dysrhythmia, the evaluation. We're maintaining cardiac output, stable vital signs, no dysrhythmia, experience decreased anxiety, positive attitude, confidence and ability to act in an emergent situation, and then express understandings of dysrhythmia and treatment. The best thing you can do is educate your patient on how they can best take care of themselves, them and their family members. So here's your question number two, and you can pause it here if you need more time. And the answer being second degree type 1. So here's your rationale. And one of the things that I want you to remember as we're going through, and we'll practice NCLEX questions, and you practice them on your own or take answer questions in the book, even if you get the answer right. If there is a rationale, it is important that you read it. You need to make sure that you are answering that question with the same thought process as the tester is. And then adjunctive modalities of management used when medications alone are ineffective against dysrhythmia. So we do pacemakers, cardioversion. So they will try to get a patient out of AFib by medication first. If it does not work, cardioversion is when they take the electrical pads, like if they're from a code, and they will literally stop the patient's heart and restart it, kind of like restarting your computer. And then defibrillation, and nurses responsible for assessment of the patient's understanding regarding the mechanical therapy. So you need to make sure they understand about their pacemaker or their defibrillator that they're putting in. Sometimes they do defibrillators and pacemakers. They're a combo part. And then, of course, if they have to have cardioversion, maintaining the patient not having anxiety, they do sedate them before they do that. You have electronic device that provides electrical stimuli to the heart muscles. That's your pacemaker. You have permanent and temporary ones. Pacemaker generator functions. Um, and the NASB BPEG code for the pacemaker function. So this is where they put the pacemaker in. Most of the time, they may put it on the left side of of the heart, sometimes on the right, and this is how it's implanted and how it works. The complications of a pacemaker use so if you have a patient that just had a new one put in, infection, bleeding, or hematoma formation, dislocation of lead, skeletal muscle, or phrenic nerve stimulation, cardiac tamponade, and pacemaker malfunction. I had a patient who his first pacemaker, it caused it had like an electrode loose or something. It kept causing like an electrical shock. So they went back in, put another pacemaker in, and then the same patient went out and tried to take a hatchet to get a stump out of the yard, and his pacemaker went through his skin. and they ended up putting the pacemaker on the other side of the chest. I don't think he's been doing that anymore. So we treat tachy dysrhythmias by delivering electrical current that depolarizes critical mass of myocardial cells. And when the cells repolarize, the sinus node is usually able to recapture the role as the heart pacemaker. In cardioversion, current delivery is synchronized with patient's ECG, and in defibrillation, current delivery is unsynchronized. And so there's actually a button on the pads on the machine, and you can either push it and say you want to deliver the charge synchronized or unsynchronized. And so this is paddle placement for defibrillation, and the one on the right is for children. And so you want to ensure good contact between the skin and the pads and the paddles. Use conductive medium 20 to 25 pounds of pressure. You place the paddles so they do not touch bedding or clothing and are not near the medication patches or oxygen flow. And if cardioverting, you turn synchronizer on, and if defibrillating, you turn synchronizer off. You do not charge device until ready to shock. And when you get ready to shock somebody, you call clear 3 times. And look and actually visually look and make sure nobody's even leaning on like the metal post or anything on that bed. And as you can see, it says this here: ensure no one is in contact with the patient, the bed, or the equipment. So, if I'm getting ready to shock, I'm going to say charging, and then I'm going to say clear, please clear the bed, and shock being delivered. Okay. And so then you have implantable cardioverter defibrillators, the devices that detect and terminates life-threatening episodes of tachycardia and fibrillation. And it's also an anti-tachycardic pacing that goes along with it as well. And here's an ICD-9 implanted. And so nursing management after permanent electronic device insertion, you would do an ECG assessment, a chest x-ray. The nursing assessment, um, you're going to check for you're also going to check the incision site, signs of ineffective coping, level of knowledge and education needs of the family and patient, and of course, a complete head to toe assessment. And that ends this presentation.